modern gamma knife has been applied really since that time to the treatment of essential tremor and to Parkinson's tremor with radiosurgical thalamotomy. And here's an example of a modern gamma knife machine and a lesion performed with that gamma knife. There have been innumerable studies of this, I think over 20 at the last count. This is a summary from a recent comprehensive review. And what you see here is that there's some variation, although all treat with relatively high doses of 140 or more gray. The outcomes are similar, about 80% of patients getting significant relief of their tremor. The largest of these studies by Young et al., shown here, treated, I think, 165 patients with more than 200 lesions. So 42 of those patients were actually treated bilaterally. And what you can see here again is that 80% were responders, and the average improvement was about 50 to 60%. Another recent study, also a large study by Kushkabedi et al., shows this graphically, where you can see that in black here you have patients preoperatively with relatively high tremor scores of 3 or 4, shifting postoperatively over a period of 6 months into scores 0 to 3. And then that was, again, in about 80% of patients producing significant improvement. I think in this era, it's also important to discuss the rise of focused ultrasound, which is a similar technique and one that was actually explored by Lars Leksell, early on in the 50s and 60s. The idea here being that instead of using radiation, you can use the focused ultrasound to produce a similar lesion. It has the potential advantage of being able to do a trial heating to 46 degrees centigrade in order to see the effect, look for any side effects, etc. It has also produced, I think, a similar effect if you look here at the results from this New England Journal study. Again, the majority of patients are having a very significant response, with about 80% or more having a meaningful response. The scores using the CREST scale were a change from 18.1 to 9.6 in the treated group, with really no change in the sham group. Here again, although you do have the ability to explore side effects with this trial stimulation, this trial heating, there was still a significant incidence of mostly transient paresthesia and gait disturbance, so 9 and 14%. That's compared to about 7-8% in most of the studies using gamma knife, so probably similar. As far as the technique that we use today, the typical target, the one that I was made most familiar with, is an X of 14, Y minus 6, Z of 4 above the ACPC plane. If you look at the different papers, there are variations on this, and many people will measure the length of the ACPC distance and divide that by 4, etc. Those variations, I think, are not terribly significant. Typically, therapy is delivered in a single fraction at 140 gray with a 4 millimeter cone. There were some early reports by Oye and others that suggested that more medial and anterior targeting was recommended because that is a bit safer. However, over time it was found that you could get away with a target that is more or less similar to what is described above. People have commented that this is significantly higher than what you typically target in DBS. And to just illustrate that a little bit, this is the usual DBS target that I use, which is similar. It's usually a X of 14, Y of minus 7, and a Z of 0. But you have to remember that you're really placing the tip of the electrode there. And so your trajectory looks something like this. If you find the midpoint of your 4-contact array, it's something closer to that location, and that really approximates the thalamotomy target that most people are using. So I think that they're not terribly different, although perhaps we do tend to be a little bit more anterior and medial to avoid the meaningful side effects of gait disturbance or paresthesia. To consider a couple of the adaptations of this technique that we and many others have been involved in. So we began about 10 years ago to use a frameless technique using a Varian TX system. We found that using the thermoplast mask, we had good evidence of its accuracy and felt comfortable that we could perform thalamotomy actually using that technique. To begin this, we actually conducted a study where we, again, did this same targeting that I showed before. We then, in the first 6 patients, went back and showed our accuracy. And what you can see here is that in those first 6 patients, the average error in three-dimensional Cartesian measurement was 1.1 millimeters, so really quite accurate. Over the first 27 patients that we performed this on, we again had similar efficacy to what has been shown previously with Gamma Knife, that you had really all but 2 or 3 patients responding quite well, and then here you see evidence of the spirals and lines being drawn in some of these patients. Again, our feeling was that this was a useful way to perform it without needing a stereotactic frame as you might with the traditional Gamma Knife systems. We also went on to adapt some of the techniques that we had been using in DBS, particularly this advanced nonlinear transformation that we had been doing. What this is that you take any particular patient scan, and because there is variability in the anatomy of every patient, it is useful to normalize that scan by doing a point-by-point deformation onto a standard atlas. Once we have that standardization, that normalization of each scan, what we were able to do is basically take all the information that we were learning from our DBS surgeries and apply that to every voxel in this standardized atlas space. In doing that, we were able to assign essentially a tremor control score to every voxel of this atlas, and then morph that back into a three-dimensional brain space like this. Using that technique in our DBS surgeries, we were able to demonstrate that the computer basically predicting where that lesion would be was more accurate than a surgeon would be doing the same standard, the standard targeting using either direct or indirect targeting. If you look at what that does for the VIM target, you can see that if you took all of that raw data and tried to decide where you should target based on the previous 100 patients of raw data, it would be difficult. It really covers about half the thalamus. However, after transformation, it really focuses quite nicely onto the VIM portion of the thalamus, and that can be then customized by applying that with the reverse transformation to the particular anatomy of the patient coming up. We applied this in our most recent SRS thalamotomy patients and found that we were having a good result with that technique. Several centers have also applied DTI imaging to SRS thalamotomy and to actually focused ultrasound. The first of these studies by Sammartino and Hodai in Toronto demonstrated this with their focused ultrasound technique. They used DTI to define the medial lemniscus as well as the internal capsule, and then triangulated between those two to identify where the VIM should be. In doing so, they were able to improve their targeting and to show that this corresponded to what they thought was the best VIM target. Similarly, the UCLA group with Dr. Paradian have used DTI identifying the supplementary motor cortex and then identifying fibers from the thalamus to that structure. They felt that this was the best target, and they used that to identify in a single patient the optimal place for lesioning. You can see here, compared to the typical atlas target, that it is a little bit anterior and a little bit superior. Again, that may be a more meaningful and tailored target for individual patients. So in summary, I think SRS thalamotomy is a valuable therapy for tremor. It's typically implemented in patients who cannot undergo DBS surgery or open surgical thalamotomy. Bilateral therapy is typically avoided, although some series, particularly that young series, largest series, had 42 patients in whom it was successfully performed without significant complications. So it's possible. I think that is now being tested in patients using focused ultrasound. It is possible to use it, although that is typically avoided if possible. Frame-based Gamma Knife has been most typically used, but frameless Linac is also effective. And DTI and computer atlas deformation, like I showed, are being used to customize individual targeting, and I think improving the technique in that way.